So this roadshow is an opportunity for us, and when I say us, I'm talking about us from a kind of system-wide way of working. So we've got kind of colleagues here from the voluntary care sector, we've got colleagues here from the health sector, and also from social care sector as well. So we're hopefully going to demonstrate how we have been acting as one and how we've been able to meet the needs under that kind of umbrella of acting as one for the local communities. Okay. So I don't know how much people know about transformation and how much kind of down the journey that we're kind of getting to and where we started at the beginning of the journey and where we're at now. But hopefully after today's session, you might have a bit more knowledge about kind of transformation, about what we're trying to achieve, about some of the really positive work that we've been doing and how we've got to where we're at now. The caveat there to that is that we've still got a lot of work to do, okay? So even though we've got some really good things that we can celebrate today in this virtual room, we're still kind of not at the end of that journey yet. So it'd be really good to kind of start to get everybody involved in that journey as well, like we haven't been so far. As I said, I think most people have muted themselves, so that's really good. If you haven't, if you could do that, it'd be great. If there is any questions that you want to ask as we're going forward with the presentations, please put them in the chat. There is a section at the end where we hopefully will be able to do some Q&A. But again, I've seen the really good content of what's coming up, so hopefully a lot of that might take a bit of time is what I'm trying to say. So we might not be able to answer all the questions in this hour session, but our commitment to you is that if we have some questions that we haven't been able to answer, then we'll happily kind of take those away and then we'll answer those questions and share them after the roadshow today, if that's okay. As always now, I've been reminded about this. If you do want to post about the session on social media platforms, then please do. And we have the hashtag Healthy Minds Roadshow. I'm sure that Natasha might put that link into the chat. And also, I think, Natasha, you're going to pop the link of the partnership website into the chat as well for people to look at. Is that okay? So I think that's my introduction from now. So I'm going to hand you over to Usman and Eva, and we're going to look at, they're going to kind of introduce some of the work and the Community Mental Health Transformation Programme, and just give you a little bit of a kind of update of where we got, why we're here, and what we're hoping to achieve, I think.
Thank you very much.
That's thank you.
Hello everyone. Nice to see some familiar faces. So I think some people might be familiar with some of the reasons, well, some of the things we might talk about, but I guess thinking about why we're here. So for people who don't know, there was a national mandate from NHS England which came around pre-COVID. The original mandate came out thinking about that we need to look at our community mental health services because as they were functioning at the time, we knew there was lots of challenges, lots of barriers, and I guess the mandate from NHS England was thinking about how we improve our community offers to deliver mental health support as a system to people and the population that we work with in Bradford.
I think some of the recognition of the understanding was about gaps in services, people falling through gaps or not being able to get the support and care that they needed. So thinking very much about how we create a service that is much more seamless and that I guess that we have less barriers.
So I think as part of that, part of the work that we undertook was to involve kind of engaging with our other partners that we work with, so listening and hearing from other people who are delivering mental health support within the district, engaging with service users, so speaking to people who access our services and really kind of listening to what their experience has been of services and kind of if they have any ideas, suggestions, solutions in terms of how services could be different or could be delivered differently in the future. All this feedback has been used to then kind of think about the design of the model. I guess some of the things that we've been hearing in terms of things that we need to address, which we know about, are things like, as Eva referenced, people stuck between primary care and mental health services. People not fitting into boxes, so we know that sometimes our services can have quite rigid criteria, and we know that humans are dynamic and we don't always fit in boxes. So I think that's something that we've really been keen to kind of embed into the model design, thinking about how we don't just put people in boxes and make sure that we're flexible depending on individual needs. We heard a lot about long waiting times and waiting times to access different services. Often people prefer ending up with the wrong service and then requiring multiple assessments at different points of their care journey, which we heard was not ideal, and it was kind of often frustrating for service users, and it wasn't ideal in terms of that wasn't the right process for service users.
Yeah, thanks, Usman. So I guess thinking about long waiting times and then thinking about where we might be able to work together to understand what people's care and support needs are and how they might be met across the system. So thinking about working collaboratively with partners in partnership, I guess, with VTSE organisations and together with health and social care, and really thinking about what's available within local communities so that we can link people in. And the hope is that then waiting times are reduced because we're able to access support in a wide variety of places for people.
I think we almost see a lot of people, and I think what we heard was that there was lots of people who might experience different mental health difficulties at different stages of their life, and I think it was thinking about there is lots of great work happening there in different communities delivered by different services. So it was thinking about how we work together as a system to support individuals at different points of their care journey, depending on what their need is.
Yeah, I think that just prompted me to think, Usman, about, I guess, people stepping up and stepping down or moving through a pathway, again, in that seamless way. So people's needs change and the dynamic, as you said, Usman, and that people might need less at some points and more at other points. And how do we get that right in a timely way?
And then I guess lastly, but I think this is kind of a national drive as well, thinking about health inequalities. We know that people across nationally, but particularly thinking about Bradford, for example, we know that there is health inequalities faced by different minority groups, depending on where they are in the district and depending on what their kind of ethnicity might be, for example. So part of this work has been very much thinking about then the health inequalities, what work is being done already to support some of them minority groups or to kind of engage some of them minority groups, and I guess thinking about as a system, so as an NHS organisation, but also as a system that delivers mental health support to people across Bradford. How are we working together to reach these communities who are experiencing health inequalities? And hopefully we talk a bit about that. With all this feedback, we've thought about developing what we have designed our framework, which...
Yeah, thank you, Rose. So this is our Healthy Minds framework, and thinking about what Usman and Eva have just talked about, this was... Can I just ask, I think somebody must not be on mute, so could I ask you again really politely to kind of put yourself on mute if you're not already? That'd be really great. Just because I get very easily distracted, so that's kind, thank you. So this was our framework that we developed. We've developed this with service users and carers and with stakeholders and partners as well. I'm not going to go too in depth with this because I'm really mindful of time and we're already running over. But I guess thinking about all the content that Usman and Eva have just spoke to you about, and I suppose this was where we came at that. We would start to develop a framework where nobody would fall through the gaps, where there wasn't any barriers and that people would have warm handovers, so that when you need some care and some support, actually the services around you will scaffold you to get that care and support and help. So again, I'm not going to go too in depth about this. This is on the Healthy Minds website. I'm happy to answer any questions about it at the end if people want to have a bit more knowledge about it or a bit more information. But hopefully it's really self-explanatory, because we did want a very clear visual that kind of explained that actually what does supporting community and healthy, that's okay, and healthy communities look like, and community support and specialist community support. So I'm going to leave that there. Okay, so thanks both. So I'm going to move swiftly on because I know we're running out of time, or above time. So I think the next presentation that we've got, or the next conversation that we're going to have, is with Ross and Nadia, who are both work within primary care, and they are primary care mental health practitioners. And I think they're here to give a brief overview of their role, of what practitioners do within GP practices, and also I think the plan is to bring some case studies of some of the people that they've been supporting and helping. So over to you, Nadia and Ross. Thank you.
Thanks, Lisa. Hello and welcome everyone. My name's Nadia, and I am the primary care mental health practitioner for the Primary Care Network Affinity, so in other words, PCN Affinity. My PCN covers the geographical areas of Queensbury, Clayton, Wyke, Shipley, Thornton and Denham, if most of you are aware. So yeah, as a mental health practitioner in primary care, our role is to act as the bridge between primary care and secondary services. So we see to adults who are experiencing moderate to complex mental health difficulties. And generally what happens is individuals will first see to their GP, and if appropriate, we will receive a referral to conduct an in-depth mental health assessment on that patient. The primary aim of our service is to offer support and direct individuals for their emotional and mental health needs to the right support at the right time. And we do this by developing treatment plans tailored to individual needs. We accept referrals from... We accept referrals from clinical professionals at our registered PCNs. These professionals may include the GP, social prescribers, at times health and wellbeing coaches as well. So yeah, moving on, what I will do now is I will present a real life case example, which will help you to understand the practical support offered from the point of referral. So a few weeks back, I received a referral from the GP for a white British 35-year-old male. His mental health background history included adverse childhood experiences. He was a victim of domestic abuse, bereavement of several friends and family who were significant to him, and lots of unresolved historical trauma. In the assessment, we identified that as a result of his background history, his ongoing struggles included anxiety, paranoia, low mood, constantly worrying about things that he couldn't control, and inevitably his past experiences which were not resolved. Although he identified his struggles, I also tailored the assessment using a strength-based approach and mind mapped his current strengths and goals, which was key in terms of tailoring his plan and his treatment plan on what would work for him and what on the basis of his needs. It was very important to also address the fact that he did self-refer to Bradford and Craven talking therapies. However, after the assessment, he was discharged on the basis of not meeting the service needs and being too complex. So this inevitably provides an example of those patients who was, falling between the gaps, so not meeting the needs in primary care, and also being too complex, for secondary care, and that's where we come in. So his treatment plan included conducting an intervention with myself. So we looked at reframing unhelpful thoughts, grounding skills, and following on from this, he was then signposted on to the core provision, which is a new service offering mental health assessment. And my colleagues will go into this in more detail later on. But for now, I will hand you over to my colleague Ross.
And that's me. Thank you very much. So I'm obviously the same position as Nadia. I'm in 5 Lane Ends area, so my geography in Bradford is terrible, but I know it covers Thorpe Edge and the Rose area, Eccles Hill, and the edge of the city, essentially. And it's just the exact same role. Like I say, there's not much difference, it's just the area. So with my case study, I had a 52-year-old female about a month or two ago now, and I've seen her a couple of times since. She had a history of DV with a partner who is also the father of her child, but they were from South Africa. So they're from a very different continent, very different way of life, and they've resettled over here, just mother and daughter. So there was a lot there to sort of go into in terms of looking at what you've achieved. Obviously, it's a big step. And we looked at that in itself because she'd lost a lot of confidence. She had a lot of anxiety and she felt she was getting bullied at work. So she hadn't had a lot of support for the domestic violence either. So what we sort of spoke about was trying to identify that and trying to work on that first. So I referred to a service called Together Women, which is fantastic. And she's not started yet. So sadly, we've not been able to see any results. But I have seen her again since, just to sort of have a little bit of a top up and a little bit more of a intervention around her self-confidence of ways to safely and I suppose professionally challenge the bully and challenge the fact that she's lost her confidence due to the way she is made to be felt at work, because she's also got hearing issues. So she conducts herself, I suppose, in a different way. Her body language is different to what anyone with normal hearing would be. So she's had complaints as well, which are needless complaints, but it's obviously still taking a bit of an effect. So what we've done is we've looked at sort of building from the bottom and do the small things. And we've also looked at referral to Bradford Talking Therapies. Again, not started yet. But like I say, I've had a review and I think I've got another one booked in about 3 or 4 weeks just to check in again to give us some more support before that starts. And then we've also spoke about going to core provision if things don't sort of materialise and if things do get worse, there is a sort of backup plan B as well. So currently plan A is to just try and work on her confidence, try and build herself up and look at her achievements and actually digest that so she can then use positive affirmations to build her own confidence, build her own anxiety, build her own resilience to then be able to move forward. And that's me.
Yeah, really great examples of what really nice to hear examples of the work that you have been doing. I think just for people on the call, I think it's really important just to highlight that historically these roles haven't been there. So I think that these people might have historically kind of been referred to CMHTs and then they will have had a long wait and then probably bounced back because their needs wouldn't have been met by CMHTs. So I guess just, thinking about transformation and why these roles were implemented is thinking about that early access and early intervention, potentially at that primary care level, bridging that gap. That's how you've just turned the two of them. So thank you both.
You carry on. You're on a flow there, Rusman. So you took my limelight, so you carry on.
I'm going to say I don't know who's next.
Oh, I'll go, right, okay. You see.
Yeah.
So, but thanks both, and thank you for sharing those case studies. It sounds like you're doing some really fantastic work, which is great to hear. So next on the agenda, and as Ross and Nadia both alluded to, we have got a service called Core Service, which is very much a service that is very, very new, very much in its infancy. Lots of work has kind of been happening so far about kind of getting that service off the ground. So I'm going to welcome some of our colleagues who have been working with that service. I think it is Hisham, Shelley, Ryan and Naz Sadiq. Is that right? Of the people who are going to, I'm not sure, is there a presentation? Yeah. There we go. Right, okay, so over to you guys. Thank you.
Right, good morning, guys. I just wanted to check that we've got our slideshow. Yeah. Okay, there we go. So we're going to talk a little bit about CORE. My name's Sadiqa Begum. I'm a service manager at Inspired Neighbourhoods, and I'll let my colleagues introduce themselves.
So I'm Shelley Doherty. I'm from the Seller Trust. I'm the programme manager there overseeing CORE.
I'm Hisham Mahani. I'm senior service manager at Mind.
And my name's Sam Jackson. I'm the new service manager for CORE at Mind as well.
Okay, so let's begin. So we're going to tell you a little bit about our vision behind CORE and what the project exactly is. So to begin with, our focus, so we've come together to bridge the gap in mental health care through providing support that is community-based, person-centred and flexible. So we're here to support those that have serious mental illnesses or SMIs that fall between the gaps of primary and secondary services. So the point of the service is to reduce strain on traditional care systems and provide support that's both personalised and goal-focused. And so the way that we do this is that we provide non-clinical mental health support, and it doesn't matter whether a person is diagnosed or is undiagnosed in terms of serious mental illness. Even if they haven't had a formal diagnosis, we offer support to those that need it. Oftentimes, there are people that are really struggling with their serious mental illness that isn't picked up by secondary and primary care, as we've heard about previously, and it can be for a number of different reasons, whether they're not ready for clinical support or that they need additional support in a different way. The point of this service is to support those people that slip through those gaps in a community base. So the way that we do that as these service providers is we offer a personalised, person-centred approach, whatever it may be that person needs in community services in the community sector. If I pass it to Hisham, who will tell about who's involved in the process.
So going back to what Lisa was saying about the transformation, what I love about this service, this is something like it's a collaboration like work. It's not only like Mind or Seller Trust or Inspired Neighbourhood or the BDCT or like the VCS Alliance. It's a co-production between everybody. So I love this about being part of a team where everybody is involved for one goal is supporting people with SMI needs and the main goal is helping people who are struggling, and we know like within like statistics that people with SMI like they have less life expectancy, and we need to improve their quality of life. So we try, this is like we try to meet together. So we meet on a regular basis every month to make sure that we are looking into the service, develop what we can develop, make sure that we are as a team mirroring each other, and try to, even like Solo Trust is having different PCN than mine, different than them in Spiderwood, but all across all lead providers, we are providing the same service. So we look about training, for example, like we train all staff the same way. So we deliver the same service. We discuss the development of the service so we can like spread this across the all providers, and we make sure that everything is taken from feedback perspective. So when if somebody, let's say, fed back to Inspire Neighborhood, we go back to the meeting and we say, yes, this is what happened. So we make sure that mine and Self Trust make sure that we take this feedback and we go and deliver that. So we working also closely with the PCN, which is like group of GP practices, work collaboratively within like health and care providers to deliver a range of services, where here my like colleague Ross and Nadia came from or received these referrals from them, as they mentioned in before. And as you can see on the presentation, we are in 9 PCNs, primary care networks. So Inspire have like a few PCNs, Siltros and us. I think now, Chen.
So during the initial assessment, the support worker and the individual will basically discuss their preferences and needs, such as the appointment type, the appointment time, whether like a day or time that works best for them, and their goals. So we offer a range of different types of appointments. So we can do telephone calls, video calls, face-to-face, and the face-to-face appointments can be held in either a home setting or a community setting, wherever they feel most comfortable. The appointments are offered on at least a weekly basis, but can be bi-weekly as well, depending on their needs. And these will be generally for up to 60 minutes. And the support worker will try to accommodate, as I said, the best time of day. Although one thing we've not actually mentioned on this presentation, we only operate Monday to Friday. Then in the initial assessment, they'll also look to set up to 3 different goals, which will guide the support. So some examples, we've had individuals with goals of trying to leave the house more frequently, or improving sleep hygiene, or managing some anxiety symptoms. As we've mentioned as well, we're not a clinical service, so we can't deliver any kind of therapeutic approaches, but the support workers can share their own knowledge and understanding of different coping skills. And then once they've set these goals, basically the individuals will score themselves on a scale of 1 to 10, and that's based on how close they feel to reaching that goal. So 1 is being not at all and 10 is being reached, and that progress gets reviewed every 6 weeks.
So as Shelley mentioned, we make sure that we support a person based on their individual goals, and we work with them to identify these and what they would feel would help them to move forward in terms of recovery. But we also support them to try and find different ways to help them. So whether that's emotional support, generally it's focused around developing basic coping skills. That can be deep breathing, grounding exercises. We also take a psychoeducation themed approach of helping people develop their understanding of mental health in general and tackle stigma, but it can also be a solutions-focused approach of helping them tackle practical issues depending on what their needs are. And this can be either directly helping them with that issue or helping them to access and engage with other services, and helping them to make sure that they have the space and capacity to be able to just focus on their mental health.
And we want to work flexibly to meet the individual's needs. So as mentioned earlier in the initial assessment, we're going to look to be able to accommodate the types of things that would affect their engagement, such as the type of appointment, the appointment time, and the goals. We'll also look to work with other services to combine support as well. So that could include services that they're already working with, or supporting a referral into other relevant services who can support with things that we might not be able to. So that could be like financial issues or housing, other things like that. If someone's a frequent non-attender, we'll always try to understand why that is and what we can do to encourage the engagement rather than discontinuing the support altogether. So obviously there's many reasons why someone might not attend, but one example could be an individual might actually feel quite overwhelmed by a goal that's being set if they feel that it's actually too demanding. So for example, if someone's not brushed their teeth in months and then there's a goal to brush your teeth every single day, that's a lot to go from. So then we could tweak the goal to say, well, can you just brush your teeth once a week for 3 weeks, and we'll kind of progress it like that. So we're always looking to alter the support based on that individual's needs. And we've just got a case study here, just to give you another example of what the support can look like. So this person was struggling with severe anxiety and had ended up selling their shares in the trade business that they had. That kind of led to a loss of identity, issues with their self-confidence, and they rarely left the home or even the bed. So they came to us for support, and we used a graded exposure approach to get them out of the home and increase their confidence. So they first started by doing walks around a park that was quite far from their local area. They had issues with, they didn't want to see people that they knew. So they started quite far away from home, and they've built that up now so that they were doing walks in their neighbourhood, and they started going to the shops and even going to family meals. They've reconnected with an old friend who supported them getting back into work, which is amazing. And now every single day they go out to the shops just to make sure that they're getting out of the house. They're not falling into that trap of getting into bed every single day. And they feel like they've kind of got a sense of purpose again. They've started helping around the house, all these different things. So just having that graded exposure, the compassion from the support worker, and some other kind of anxiety management techniques has really supported with that.
Okay, back to me. So although the service came to life like recently in May 2024, however, like across the 3 lead providers, we have supported about 135 people so far. We are still receiving referrals. We're still trying to support people. And not surprisingly, I think across the 3 lead provider, we have these 3 common themes, which is isolation, anxiety, and depression. It is like we didn't speak to each other and say, would you have, but by chance when we say what are the 3s and we would meet together, we found this is the 3. So across look like this is the theme across Bradford and Craven, where people feel like isolated, they have like an anxiety and depression. And when we're talking about these themes, like people like generally have low mood, they have stress or have anxiety, nothing to about don't want to go outside home. So we offer like home visits. When we do this, we try also to step from that to go into the community, maybe just to gradually to, as Shelley said, that we want to go step by step. Also, it's not only like with these 3, so there's other like themes. So we have like debt and finance issues, we have PTSD, employability, physical health. So also what we're trying to do with CORE is about looking about the support available in the community and how we can link with other services available and how we can support best. We look also into like groups. So we have like maybe people who have less need of this one-to-one support to set up these groups in the community. And also like see other like VCS who offer like some support and how we can signpost to these services. I'll be back now to Sam.
So just a little bit around our referral criteria and process. So there is some little bits that would exclude somebody from being eligible or sort of suitable for a referral into CORE. The first point of if the individual is waiting or receiving ongoing support access to secondary mental health services or care coordination is there. However, we are working towards more of a warm handover approach. So if somebody is sort of coming or they're working towards a discharge with those services, then we would be able to start our support and try and create that little bit of a warm handover approach. If the individual is deemed an immediate risk to themselves or others, then would exclude them from being suitable for our service at that time. As it says there, we're not a crisis service. We are there to provide ongoing support. And touching on the groups that Hisham mentioned just previously, we're looking at different methods and different ways where we can provide that ongoing support to still be just as effective, in the community. If somebody doesn't want or need, those one-to-one appointments as regularly. Individuals with co-occurring substance or alcohol issues can be offered a service, except if we do feel, or any of our practitioners do feel, that they are under the influence, or where use of those substances or alcohol causes them to potentially be a risk to either themselves or anybody else who is delivering that service to them. In terms of inclusion criteria, it's got to be 16 or above. Individuals with diagnosed or undiagnosed SMIs or complex mental health difficulties, and the individual may or may not be registered with a GP practice, but the services can only work with people who live within the PCN areas covered by that particular service. Just on the next slide, we do have an image of the core referral form. So these are the kind of details that we would require when a referral is sent into our services, and it does say that we can where to send that referral form into. So I know Ross, we've had a lot of referrals coming in from people like Ross and Jodie, and we've also just had our first referral in from the assessment team as well. So just to finally, really, the contact details for all of our services are there. Those core inboxes are the ones where referrals would be sent into for the relevant service, and then you've also got our details in terms of myself and Hisham's from Bradford District and Craven Mind, Shelley and Ryan from Stella Trust, and Sadiqa and Naz from Inspired Neighbourhoods there as well.
Thank you.
I think that's
Thank you very much. Thank you. That was a really great presentation. Lots of information, and lots of really good. Well, one really good case study of the work that you've been doing, and I know you're doing some fantastic work. And as we said at the beginning, it's very much in its infancy, but the referrals are starting to come in. So, and thinking about what we talked about in the beginning when we first started, CORE is very much about supporting people who were falling through the gaps. And I think there's some great examples of what we just talked about. I'm aware of time, so I'm going to speed us on to Laura and Claire, who are going to talk about the psychological vision and give us a kind of brief overview of what that currently looks like. So over to you. Thank you.
Thanks, Lisa. So Lisa mentioned, my name is Laura Dixon, and I'm the clinical lead for our new psychological therapies provision that sits alongside our colleagues in CORE. And I'll hand over to Claire to introduce herself.
Hi, my name's Claire McGuinn, and I work with Laura and Sarah Bambridge and a new AP, Charlotte, and we are, and I'm one of the psychological therapists in the team.
Thanks, Claire. Can everybody see the presentation okay?
Yeah, we can see it. Right, we can see it. And everybody else? Thumbs up, brilliant, yeah. Can you see it, Laura?
Well, it's just not. It's not moving along. So.
Oh, right. Okay.
I'm just going to share in a different way. Apologies, because I know we're tight for time as well, aren't we?
Right, it's technology. I think, we've got to have one little blip at some point. That's the joys of technology and how it works.
It's the. I've got 3 screens open, so that's the issue.
Yeah. 3 screens.
Now I hope. Oh, gosh. Let me just unplug something.
I suppose if you can see it, do you want to talk us through it?
Yeah, can do.
Yeah.
So thanks, Lisa. I give it up as a bad job. So essentially, I'm not going to repeat what the people have talked about. So what we've done is recognise that there's this gap between primary and secondary care. And just to highlight, that's not just us in Bradford District and Craven. That is a national issue that's arisen. So we're not alone here. And that's why there's this national transformation programme. What that means for us specifically when it comes to psychological therapy and the different services that are in existence. So you might be familiar with NHS Talking Therapies, which was formerly called My Wellbeing IAPS or My Wellbeing College. And you'll be aware possibly that there's psychological therapies within our community mental health teams. So then that meant that the gap was between those kind of two provisions. And the same issues are cropped up for psychological therapy as they have for more general mental health support. So people falling between gaps, having lots of assessments. So what we've done is configured a kind of new psychological therapy service that sits alongside our colleagues in core VCSE and our kind of primary mental health care practitioners to start to address that really and offer support to those people who are missing that support. And who we offer it for, again, everybody's stolen my thunder a bit here. So it's the same group we're talking about. It's those people. So what we might talk about as kind of severe mental health problems, and there's some diagnoses that Sadiqa beautifully presented on her slide. So not really people presenting with anxiety, depression, which NHS talking therapies would be able to support. And it's the type of, and it's for people who wouldn't need a broad range of support to help them with their mental health difficulties. So people who wouldn't need that community mental health team approach, and for people that are really wanting specifically to have help from a psychological therapeutic or a psychological support nature support. And it's people who also, again, much like our core colleagues in the voluntary sector provision, it's not for people who are having a crisis or are really likely to kind of fall into a crisis in the near future. And we've got some great services in Bradford already for those people. So it's not a need that we would need to meet in that core space. And it's actually part of a national initiative to really increase the provision of psychological therapies and access to those for people with these type of mental health difficulties. Our service is really in its infancy at the moment, and as Claire mentioned, she named our team, which are clearly a very small team, but we have got plans in place to develop that over time, and we have got a strategy to try and be more inclusive, really to follow up on those issues that were flagged in the Healthy Mind scoping work that Lisa talked about in the beginning. So thinking about how do we become more accessible as a psychological therapy service, and what do we need to do that? And we do we draw on the national guidance very clearly, and we do adhere to that. But what we really understand is that our communities, we've got a great diversity of communities across our districts, and we really want to be able to nuance our offer to those communities. So part of the work is really working with our communities and our community partners to understand where we're missing things really and what we might need to do differently and innovate around that. We work closely with our core colleagues, and we're developing those relationships. And so at the moment, we've got 2 referral pathways open to try and understand that gap better and how needs haven't been met over time. So we take referrals from our primary care mental health practitioners. So you've heard from Nadia and Ross today, and they're 2 of our referrers. And at the moment, we've got a pathway also from NHS Talking Therapies. So I think, I can't remember if it's Nadia or Ross mentioned a case where they've been assessed by Talking Therapies, and that they're not able to support people with certain difficulties because they're not trained in it, and they're kind of not able to offer the number of sessions that will be needed for people who've got a bit more complexity. So we've got a pathway in place now where they can talk to us about those cases, and then we can think about how we best try and meet those needs and where we might be able to direct someone and enable access to those different types of psychological therapy that might be more helpful, really. So I think that's the kind of key things about the service so far. And I'm going to hand over to Claire to talk about a couple of case studies, really. As I mentioned, we are very much in our infancy, so we haven't necessarily got a lot of cases to talk through about what the outcome has been, but we can talk about a couple of cases working with at the moment that kind of illustrate some of the principles that we're talking about today in terms of meeting the need of those people who otherwise wouldn't get access to services. So I'll scoot out of the way a bit.
That's certainly what we're seeing with, with our small pilot projects, is people who just would fall between the gaps, and exactly with complexity. So exactly the people who we are supposed to be seeing, who we're seeing. So one example of our case study is Tracy. So she got a small pilot project with talking therapies. She was referred through by talking therapies, complex trauma, specifically CSA, childhood sexual abuse, and things around attachment to give a kind of complex picture, and a survivor of domestic abuse. So lots of stuff gone on for her. She has what might be described as complex post-traumatic stress disorder, and she has had a course of therapy with the talking therapies, but limited improvement. So probably would get discharged and then try to refer back again. And but after a referral and assessment with core psychological therapy, she's now been offered a specific type of therapy, which research has shown to be helpful for people like Tracy. So working closely alongside in that kind of warm transfer way, especially psychological therapies already existing in Bradford District Care Trust. She has, we've been able to enable access to this therapy, in a much shorter time really than the whole process she would have had to go through. Potentially she would never have got there, So Tracy would not have been able to access this type of therapy. It's not available in the NHS talking therapies, but she didn't really need the support of a full community mental health team. So she definitely would have fallen through the gap. So successfully referred through to a therapy service that will be appropriate for Tracy in a much more timely way, with much more support than she would have got. So that's example one. Case story two, Mark. So he came through from primary care, got to see his GP, and he'd been supported by one of our community mental health teams in the past for quite a period of time, and was discharged a number of years ago, and had been, feeling kind of okay and stable since then. But a change in his circumstances kind of led him to feel more stressed and for things just to become a bit more unstable for him. So he came back to his GP and was, anxious and showing some early signs of paranoia. And that was recognised by the primary mental health care practitioner who the GP referred him through to for a fuller assessment. It worked really, really well. So he was then referred through to us, to the core psychological therapy team, and has begun a course of cognitive behavioural therapy for psychosis specifically. And also we've done some really good collaborative working with the community mental health team to support him, because he hadn't had a medication review for years, he'd just been supported with the same mental health medication since he was discharged from CMHT. So we've got a kind of a brief intervention coming through from our colleagues in the community mental health team to really support him with his medication and really to help him get back on track. In the meantime, he continues to see me, one of us, for therapy. And I think without our primary care mental health practitioners being there and before core, it's likely that Mark would have just deteriorated, and got to a point of crisis intervention, and potentially may have had to go to hospital, but hopefully and luckily we've got in there, he's getting the therapy he needs, brief support from CMHT, so that seems to be working well. Thank you very much.
Yeah, and apologies that the slides weren't working, but I will make sure that Natasha has them so she can circulate them. And just to be clear, we anonymise the case examples, so and they won't be included in the slide pack. And I guess, given the disruption with the lack of slides, I think we forgot to mention that part of our team, it will include some of the volunteer workers, which I think Millie is about to talk to you about now. So thank you, everybody.
Thank you, Laura and Claire, and thank you for that lovely segue to Millie. So without further ado, Millie, we'll let you talk about your role and the great work that you've been doing with the volunteers.
Thank you. Thanks, everyone. Thanks, Laura. Thanks, Claire. Yes, so I have got some slides, actually. I'll share. Hopefully, this is going to go okay. That one. Okay, hopefully they've come up. That's come up okay. Yes, we'll go with it. We'll go with it. So, hello everyone. My name is Millie Kafke. I am the Healthy Minds Volunteer Coordinator. why have volunteers been introduced as part of the Healthy Minds community mental health transformation? So to support BDCT, partner organisations, and also give people the opportunity to volunteer in supportive environments that enhance the way we deliver care and closer to home. It improves recovery, and there is also a direct correlation between employment, health and wellbeing outcomes, and the reduction of health inequalities as well. Volunteering opens the door to employment and education opportunities towards careers in health and social care for people who may not get the opportunity, and it's also sort of around strengthening our workforce as well by recruiting people with lived experience. I do have a little video of myself. There's the link. I'll put the link in the chat after I've done the presentation. I've got them open, so I'll pop the link in the chat. So the outcomes so far. So we've had a popular first role, which is the meet and greet volunteer role. So this is this is sort of embedding volunteers within the community depot clinics. So that volunteer is a familiar, welcoming face within the clinics, in the waiting areas, offering basic health promotion to people coming in for their depot, and signposting to local community events as well. There's been applicants who've applied for this role as part of their own recovery as well following discharge, and also applicants as well who have community language skills, which has come to be sort of really valuable in that role. The volunteer support that's in place has released capacity for staff as well. So the roles have complemented staff roles, not replace staff roles, and services have then since reached out with their own ideas for volunteer roles as well. So talking therapies, and also Laura and the team at the core psychological therapies team as well. So that's really brilliant. Can't move on to the next slide for some reason. Oh, here we go. So again, I've got a video here from Osgay. So she's one of our meet and greet volunteers. I can send the link to that video. She's talking about her role and the sort of the positive impact it's had on her, as well as the role itself and the impact that's having. And another meet and greet volunteer is Sabahat. So in terms of her, I'll talk through sort of a really short case study demonstrating the impact that it's had in terms of coming from Sabahat. So on her first session supporting the Horton Park depot clinic waiting area, Sabahat struck up a conversation with a woman who spoke very little English, but who Sabahat discovered spoke Urdu. They spoke for around 20 minutes or so about various things, and the woman opened up to Sabahat about why she was coming in for her depot medication and the support that she was receiving. She mentioned that she would benefit from further confidential telephone support, somewhere that she could speak in a safe, non-judgmental space. And so Sabahat signposted her to Guideline and gave her some service leaflets to take away. Sabahat felt proud and happy that she could have helped. Since this session, Sabahat has also supported the nurses within the clinic with some Urdu translation regarding a lady who wanted them to explain sort of more, give more information about sort of the injection, the medication that she was having, the Sabahat has supported the patient. I was like, sorry, my notes are was useful, and supported the patient regarding their missed appointment by talking to the reception staff as well, in Urdu. So I guess sort of there's elements of that there, massive elements of that there, that show the value in having that volunteer there, and that volunteer having those community language skills. So in terms of working together, so the volunteer service, myself, who's part of the volunteer service, working together with those services that we've all just heard about. So there's a talking therapies volunteer in place at the minute. So there's one volunteer appointed for that role. She's really enjoying it. She's been a point of contact for patients and visitors entering the site. She's supporting the facilitation of the psychoeducational workshops and courses. And part of her role is also gathering feedback and assisting staff as well at like local access and outreach events as well, and really promoting that service. So she's really enjoying it. as she's only been sort of doing it for the last I'd say this is like her 4th week, but she's really enjoyed it. There are 2 roles with the core psychological therapies team. So these are there's a therapy onboarder role and a group support volunteer role. So the closing date for this was supposed to be in a couple of days' time, but we've actually closed it early just due to the number of applicants and the interest for those roles. Don't want to scare you or anything, Laura. I mean, I'm scared. But yeah, so it's been really popular. As expected, as with the talking therapies role as well, that was super popular. So I'm interviewing with Claire and Sarah from the service next week. So it's just a case of sort of whittling those applicants down. There's a Healthy Minds volunteer role, which is in the early stages of development. So where I'm at with that is finalising the role with 2 practices who are interested. So the role focuses on and aligns with the PCNs to deliver Healthy Minds promotional activity within the GP practices. The recruitment will also involve the development and delivery of a training package, initially available to all Healthy Minds volunteers, but then the ambition there is to offer this to all health and care volunteers across the trust and beyond, which will be really great. There's also the working with volunteers training module, which is on our ESR, and also staff training resource, which as a team we've developed to really support that positive volunteer culture within services and teams. So that would include sort of myself attending team huddles and team meetings to deliver some sort of really some quality training around kind of what volunteers are there for, like the benefit of having volunteers in that service. And also, we've had quite a lot of success with linking volunteers into our Volunteer to Career programme as well, which supports workforce development and gives that guidance into a career within the NHS, and providing that wider support and progression for that volunteer. Just breaking down those barriers, going well. So attracting applicants from a variety of backgrounds with varying skills and experience. Like I've said, the last couple of roles that have been out have been really super popular. Putting myself out there, reaching out to teams. I'm talking about my role and highlighting the benefits of having volunteers as well within those teams. Early success stories like with Sabahat that I mentioned earlier. The roles are connecting volunteers with the people and the communities around them as well. So broadening their own networks and resources, increasing their self-esteem and confidence and their own personal growth. And then, like I just mentioned, sort of volunteers are already receiving support and guidance from Jo, who's our clinical lead for the Volunteer to Career programme. I think that's it from me. But I will, like I said, I put those bits in the chat, the videos in the chat for you to have a look at, and I believe Natasha has got my slides to send round to everyone as well. Yes.
Thank you. And thank you for all the hard work with kind of implementing some of the volunteers and getting them into mental health, especially community services, because it's a barrier that we've been trying to break down for quite a few years now. So thank you for all your hard work, and I think that presentation sums it up very nicely. Okay. Thank you, everybody, for all your presentations and all the information that I think we've all just absorbed, which has been quite a lot. I'm aware of time, and I think we've got 4 minutes before we're due to finish. I know that there has been some questions that have popped up. I don't actually have access to the chat, but I think there's one question that Rashmi's answered, and a few other bits have been popped in. So are there any questions that anybody wants to ask us at this? Well, we've got kind of a few minutes, and we'll try and do our best to answer them. As we said at the beginning, if we can't answer them, or if there's any questions that kind of come up when you've had time to kind of reflect on what we've talked about today, then please, pop something in the chat. You should still have access to the chat after the meeting's ended, I think. That shows my very poor digital sense there, doesn't it? But other than that, Natasha's email is around, and my email as well. If anybody's got anything that they directly want to come to any of us with, would be great as well. So I'm going to open the floor. There are some really great developments, yeah. There's some really great work happening. As I think I alluded to at the beginning, we are kind of still on the journey of transformation. We have got lots of kind of other ideas and things that we want to work with our communities. about how we can kind of continue to break down the barriers, close the gaps. So yeah, this is very much kind of a bit of a stock take of where we're at and the work that we've got to continue doing. And I think from my point of view, from kind of listening today, it is really great that we have done kind of so much work and we've got to this point. But I think also to showcase it like we have just done now, because we're living and breathing it, sometimes you don't always kind of see the work that's been happening. But I think we also need to think that we need to have another one of these sessions as well. I know there's lots of sessions as part of the roadshow. Please try and get to as many as you can, because there's some really great work happening out there. But we also need everybody's voices that are in these rooms as well to support some of the work kind of moving forward. So there's lots of chat. I can only see bits of it, but I think Natasha's put my email in there. So please don't hesitate to contact me, and I can at least then try and support or at least guide to get the right answers.